Thank you very much, sir. At the outset, I would like to thank Dr. Pranav Ranjan, sir, who is currently president of AIOC, for giving me this opportunity. So I'll be talking on tips and tricks for the Toric IOLs. I have no financial interest. We all know that be it the global or Indian scenario, for astigmatism more than one diopters, we have more than 40% of cases who are undergoing cataract surgery. At the same time, the outcome of toric IOLs have become very predictable in terms of the investigative tools and the lens design we have, and very good rotational stability is there. So we are standing in a situation where we have very good understanding of corneal astigmatism, we have very good capturing devices, we have from manual marking to image guided system for appropriate orientation of the lens, and lenses with better rotational stability. So toric IOLs are the need of the hour. I'll take you back to 2011 when I did this case. This young boy in teens had corneal tear with lens trauma. I did aspiration of lens, corneal tear repair, and there was no intact capsular access. Still, I decided to implant a toric IOL that time, and a patient could read 6/9 unaided. So with this basic platform, I introduce you to the 10 commandments of toric IOLs. First, that is the myth associated with it, that it needs lot of instrumentations. Patients in my region are not willing to pay extra, or residual astigmatism, if left, will lead to unhappy patients. It's not like that. You have to do a good counseling and you try. Never jump to the conclusion of toric IOL implantation based on refraction only. You have to look at the corneal astigmatism and then you counsel the patient about astigmatism. And case selection is very important. It is very important to understand how a phaco toric IOL differs from phaco in routine cases, because you may have to spend some time preoperatively in marking. Intraoperatively, you have to orient the lens in proper meridian. And if pupil comes down, then you will have difficulty in identifying the mark points on the lens. Then dry eye evaluation, any corneal opacity, and posterior segment proper evaluation should be there, otherwise it may affect the outcome of the patient. Here if you see this patient on lens star we are trying to capture, and very poor patient cooperation is there. If patient has very much dry eye, he may not able to fixate on the target. So what reading you are getting is not appropriate. So in this case, toric IOL is being implanted and pupil has come down heavily. So after implanting the lens, it is difficult to identify where are the marks. So I have to retract the iris to see the 3 dots exactly, and now you can see, I'll be able to see those 3 dots. Yeah, now you can see. So I tried to align this IOL by rotating, but what happened? In the meantime, I saw there was excessive rotation of the lens. So what was the problem in this case? That one haptic was in the bag, other was in sulcus. And retrospectively seeing the video, I can make out, but on table I couldn't. So I missed this case. So there was gross rotation, so I had to align it again. Second thing is which case you should take up, with high astigmatism or low astigmatism. So a lot of considerations are there. If you take up small astigmatism, you will be missing if orientation is not proper, residual will be low. If you are taking high, if rotation is there, then high residual will be there. So based on that, the bottom line is the counseling should be proper, then only you take up the patient. Then it's about measuring the correct astigmatism. Apart from the what I said earlier, you have to take into account the head tilt and cyclotorsion also, because these affect the measurement of axis of astigmatism. Then when you are doing optical biometry, the only data that you can look at to validate your examination is the standard deviation for all the parameters that you have. In A-scan by ultrasound biometry, you can look at the graph, A-scan spikes and interpret. But here it is the standard deviation that will give you insight about whether your measurement is appropriate or not. Then posterior corneal astigmatism has emerged very heavily, and we have to take care of that. Barrett toric calculator theoretically takes into account of that posterior corneal astigmatism, and there is a fair amount of agreement between this predicted PCA and actually measured PCA. So if you don't have an instrument which actually truly measures PCA, this Barrett theoretical assumption will help you in your astigmatism cases. Then this Baylor nomogram is for with the rule and against the rule astigmatism of posterior corneal astigmatism. So if against the rule means if everybody is against you, means you are weak. If everybody is with you, this I am telling you the mnemonic to remember. So if it is against the rule, means you will be underestimated. And if everybody is with you, you will be overestimated. So if you remember this mnemonic, you can always remember that in against the rule astigmatism, you have to lower the threshold, and with the rule astigmatism, you have to up the threshold. So knowing your SIA is also very important. It can be calculated online. Then we have online incision location also on LensStar. You can manipulate to see how much residual astigmatism is there, as you can see on this in this video. Earlier we were dependent upon only the what company gives us, but here in real time scenario you can adjust your location to look at a feasible location as well as the residual astigmatism. Then biometry should be proper. Then one thing, if in LensStar, suppose whatever Barrett formula is there, that at the time of installation, whatever updated version is there, that will be installed. But the online is always updated. So it's not that online, if you are using it is because you have not paid for that, it's free, so it's not good. No. It's very updated, so there is no. It's not wrong to use the online Barrett calculator for marking. If you have image guided, that is the best. Otherwise, you can equally rely on manual marking, and 3-point marking is a good option. Then knowing the type of lens you are going to use is also very important, because if it is plate haptic lens and if it comes out of the bag and pupil has come down, I have till date in premium lenses only one case I had a complication. That was the plate haptic toric IOL. I was trying to push it and I pushed it very much, and that plate, it torn the capsule. So you have to keep that in mind. The lens design is also very important. And then washing the viscoelastics from behind the IOL is also very important. Otherwise, there will be a gross rotation. Many times we see my post-operatively it rotated this much, that much. No. Lenses are very good. They adhere to the capsule very well. So washing viscoelastics is very important. So to conclude, microscope should be coaxial. Undershoot the desired meridian so that you have little room to adjust the toric IOL along the appropriate axis. And if there is a collapse at the end, then re-ensure the orientation, because collapse of chamber may rotate the lens little bit. So thank you very much.
Thank you, Dr. Sujeet, for comprehensive tips that you have given. One thing which always comes to the mind is the cost factor between manual marking and a digital marking system. So what I have, my experience is manual marking is equally good, and therefore what I advocate is that it should be taken up by every surgeon who is doing a cataract surgery.
Absolutely, that is why
that should not be a bar, because the error, the margin of error is very, very minimal.
Absolutely, that is why the first slide I put was myths about toric IOL. It needs a lot of instrumentation. No, the first slide was no. With manual marking, you can do it very well.
And marking on the slit lamp, 0 to 180 degree, with a 26 gauge needle.
Yes.
I mean that gives you a precise axis.
Yes.
So that is one thing which I have learned, that there's hardly any difference between a manual marking system, the ultimate result, and the.
Yeah, I didn't add the video because of lack of time,
right.
but I
so
just passed by mentioning 3-point marking what I showed. Absolutely,
and
sir.
Everyone who is doing a cataract surgery, this is a very, very forgiving surgery. Yes. Toric implantation.
Absolutely.
So everybody should take up toric implantation.
And we have a lot of cheaper lenses available now for toric.
Yes.
So
and it doesn't cost anything. It doesn't cost anything extra except for your skill.
Yes. Absolutely, sir.
Okay, thank you so much.
Dr. Sujeet,
Sujeet,
you
are a
have
senior person.
mentioned
Please take a
another
chair
thing,
here.
very important thing,
Please
that
take
the
a chair.
online Barrett Toric calculator is better than whatever we have been supplied in the IL Master 700 and others. Or I have, every time I have gone through the both two, online Barrett Toric calculator is better than whatever I have been given, provided by the IL Master 700.
Yes,
So
absolutely.
online-
This is very important
This is
point.
very
That's why I
important.
highlighted. So never feel that you are using the free version, so it's not something up to the mark. No, that is more updated.
Yes.
In your machine, once installed, then installed. But there it is currently updated.
So it is very important to use online Barrett Toric calculator.
Yeah. Thank you, Sujeet. You take a chair